again, thank you everyone for joining this Academy of Nutritional Medicine webinar. We're absolutely delighted to have Professor Kai Schulze-Forster with us from Germany. He's the CEO of the laboratory CellTrend, and this is going to be, I hope, a very exciting webinar. The title is Autoimmune Antibodies, a Missing Piece in ME, POTS, and Long COVID. And just before I introduce him, just to say, please do put any questions or comments in the chat or the Q&A box, as always. It will be recorded and put up on the past webinars as well as past events tabs on our website. If we do extend beyond 8 o'clock today, because this is the first time we're presenting this and there is some complexity to it, please don't worry if you have to leave. The entire webinar will be posted there. And after Professor Kai has spoken, I will add on a small piece myself. And after that, we'll go on to the questions. So Professor Kai Schulze-Forster is a pharmacist, molecular geneticist, and biotechnology expert with over 3 decades of experience in pharmaceutical research, diagnostics, and biotechnical innovations. He completed his pharmacy degree at the Free University of Berlin and earned his PhD in molecular genetics at the Robert Koch Institute, where he investigated biochemical and genetic mechanisms relevant to human health and disease. And he has been the author or co-author of quite a few of the articles that we will be referencing in this presentation. So, Professor Schulze-Forster, thank you very much. Over to you.
Thanks. Good evening to UK. It's a real pleasure to be here, and thank you for the organizers to invite me for this talk. You see here the title, the Autoimmune Antibodies. It's a missing piece in ME, POTS, and long COVID. Yes, autoantibodies. Autoantibodies are not new in diagnostics, so they are well known and widely used in diagnostic procedures. For instance, for lupus, rheumatoid arthritis, Graves' disease, diabetes type 1. But have all facts been told? And nowadays we think and we know the answer here is no, because there is another class of autoantibody biomarkers that has not received enough clinical attention in the last years. And these autoantibodies are directed against a very interesting specific structure in our body named G protein-coupled receptors, or abbreviated GPCRs. And that is from today, included some minutes ago into the presentation here in Germany from a newsletter called DocCheck. Have also an article that we have the same situation here, that ME CFS patients speak up and they feel ignored, stigmatized, declared sensitive, and the article is describing of facts from medical failure to the hope for fair care. So here is the complete link for the article, but it's in German, sorry. Coming back to GPCR, here you can see the typical structure of such a receptor molecule. It's connecting the outside of a cell to the inside, the intracellular part of a cell. It's a long amino acid chain. It's a protein and passing 7 times the cell membrane. And so the name is also the 7 membrane passing receptor. And this, why is this so important, this structure? Because we have 770 different types of receptors for different binding partners. These are the ligands. And we have a lot of different structures binding these receptors. There are peptides, big proteins, odors, pheromones, hormones, and neurotransmitters. And also for modern drugs, it's very important because about 30% of all drugs are interacting with these receptors. And so well known, here an example are the beta receptors, and you can block it, for blood pressure treatment, high blood pressure treatment, you are often using beta receptor blockers. And there was also a Nobel Prize for the discovery not so a long time ago in 2012 for these receptors, and also here stating the relevance that these receptors regulate virtually all known physiological processes in humans. So I think it's clear why these receptors are so important for our life. And I would like to take you on a journey to describe discovery of GPCR autoantibodies as a diagnostic tool. But before, some mechanistic insights. So the ligand binds to the receptor, and inside the cell, at the end, we have any effect. And this is like a model. So it's like a doorbell in a house. And so then the GPCR transmit a signal, also information from the outside to the inside of a cell. So you press, the finger is like the ligand. Here, this button is the receptor, and then you have a signaling inside ringing the doorbell. Now we know that autoantibodies can bind the receptor. And there is the question, are they also activating the receptor and starting the signaling like the natural ligand? And the answer here is yes, they activate the receptor like the natural ligand. So you have the same cascade inside the cell, generating of so-called second messenger, and at the end you see an effect in the cell. The first description of such antibodies was made using a bioassay. So that is the reason that we have knowledge about the activity of these antibodies, that they're really activating the receptor. So nowadays, not longer used, but very important for the first discovery and for the mechanistic understanding. The model was using red cardiomyocytes. And in the cell culture, if you add a preparation of autoantibodies, they will activate, for example, beta receptor, and the frequency of the beating rate is going up if you add such a preparation. And such a preparation maybe is IgG, immune globulin, from a patient. So this was the first tool to discover and to assay such antibodies. But the bioassay is not used for routine diagnostics because you use primary cells from animals. You cannot assay many samples at the same time, so no high throughput. The effort to do the assay is high, and the specificity is only medium because several receptors are present on the cells. So, and it was our task at CellTrend to transform this assay into another technique called AYA, and this is abbreviation for enzyme immunoassay. to overcome all the problems. So there is no longer the use of primary cells. It's possible to assay a lot of samples in a short time. The effort is low and the specificity is high because only one receptor is present in the testing system. And this IR technique was then the start also to discover more antibodies, do really research with great cohorts of patients, and to find a lot of very interesting results. And I will present some of them in the next minutes. So we compared also both assays. This is solid phase assay against the bioassay, and the correlation is very high. Here a brief summary how our assay is working. So we are really using complete receptor molecules in its native receptor conformation. That is very important. We have this solid phase tool. It's called a 96 microtiter plate. In each well, you can perform one assay. So with one patient sample, for example, we add then in the assay the patient serum. If there are any antibodies against or binding the receptor, they will bind. And at the end, they are marked with another antibody directed against human antibodies and labeled with an enzyme with horseradish peroxidase. And at the end, we add a substrate, TMB, tetramethylbenzidine, and this is then turning to an oxidized colored form. And this is now for us a platform technology. We can use a lot of different GPCRs here at the coating step on the microtiter plate. And so we are able to generate assays against a broad range of different receptor molecules. Our first diagnostic marker was this angiotensin II receptor subtype 1 to detect the autoantibodies against this receptor, and our abbreviation is AT1R. And the intended use is to detect non-HLA antibody-mediated kidney rejection. So we are in the field of transplantation medicine. Was also for all of us a big surprise that an autoantibody is involved or useful in transplantation medicine. And there was a great gap of knowledge because some patients, after receiving a kidney transplantation, showed a rejection of the transplanted organ from the type of antibody-mediated rejection. But no antibodies were found in such patients, so it was called the non-HLA rejections. And we were able to show together with our clinical partners that patients with antibody-mediated rejections, but without LAA-specific antibodies, had a high level of AT1R antibodies. And this is then a control group. Other type of rejections, the cell-mediated rejection, we were not able to detect high levels of this biomarker. So it was really specific. And also one of our important collaborations partner, Professor Dushka Dragun from Charité, unfortunately passed away some years ago. She was really a great clinician and researcher, showing a lot of, giving us a lot of insight into the mechanism and of these autoantibodies. So she performed an experiment transferring antibody preparations from a patient into a rat transplant kidney model. And she was able to show that only by transfer of this preparation with the antibodies was then able to generate the same symptoms in the animal. So kidney rejection after transplantation. So a very nice evidence that only the antibodies are causing such severe conditions. So what is the reason behind that the antibodies alone are sufficient to cause such severe transplant rejections? So we think that these functional antibodies are a second level of activation of the receptors. So they act independently from the natural binding partners, the natural ligands, and cause sustained signaling. So signal all the time, on. In contrast to the natural ligands. The natural ligands is binding the receptor for a short time and then disappearing. But if an antibody is present in the serum, the antibody is for a long time present in the serum. And this sustained signaling will cause then fast onset of organ damage, for example, vasculopathy, and then for transplantation, then rejection of the organ. So coming back to our house model, I think it's very easy to understand if someone is continuously ringing the doorbell, this will sooner or later wreck your nerves inside if they're ding dong, ding dong, ding dong, ding dong all night, all day. And that's very unphysiological. So, and the reason is the antibodies are present for a long time, but the natural physiological ligand normally is present for a short time. And then you have really unphysiological conditions. Next step in this journey. So we have a correlation antibodies with disease conditions. We know that the functional antibodies are really causing or is like a root cause for the problems. So it's our aim to treat patients, to cure them. So the idea is to remove the antibodies from the patient. And Dragun did some experiments in 2005. So was here published in the New England Journal of Medicine, a well-known journal, high-ranking. We call it the translation back from bench to bedside. So there were some patients with beginning rejection, and at this time, plasmapheresis was used to remove antibodies or also receptor agonists. And this therapeutic proof of concept was successful. So, and here you can see some results that in a treated patient group compared to an untreated patient group, the graft survival is much more higher. So, therapeutic approaches. Nowadays, we have some disorders where we see elevated GPCR autoantibodies. And what is possible to help patients? Again, the removal of the autoantibodies, not only by plasmapheresis, also by immunoabsorption or another technique called immunopheresis. You can also use receptor blockers. Another therapy is IVIG, this is intravenous immunoglobulins, and you can destroy the B cells. The B cells are the white part of white blood cells producing antibodies by some drugs, anti-CD20, anti-CD19, for example, here the name is rituximab. But I would like to point out that all these therapies are under evaluation, and nothing of them is now part of the normal healthcare system, also in Germany. So now I turn to ME. I think the audience is familiar with this condition. This is a very complex, not really fully understood condition, but very often triggered by a viral infection. And we work together with Carmen Scheibenbogen. She is the expert here in Berlin and also one of the acknowledged experts in Europe. And we are working together also in the pre-corona, pandemic situation. So this is a publication from the year 2016. At this time, no biomarkers were available for the diagnosis of ME. There are some questionnaires like this, and we test a group of patients from Carmen Scheibenbogen. This is a CFS Berlin group. So in Germany, the phrase CFS is more common than ME, but I learned that in UK, ME is more common to describe this condition. And here you can see how we are normally working. We are comparing always a group of patients with a disease conditions and compare it with patients or healthy controls. So each circle here is one patient. And at the end, we analyze, is there a difference between both groups with a specific marker? And nowadays, we have a lot of markers. So we run patients against a panel nowadays about 40 different markers. And then we saw at this time that we have some significant differences between the groups. Here for the markers beta 2 and the muscarinic receptor 3 and the muscarinic receptor 4. So a short summary of the study. At this time, we were able to see positive results in about 30% of the patients. But also, for us, also important that we have in some markers no differences. So we have a specific effect on some autoantibodies, and other autoantibodies against GPCR are not able to discriminate. And you see the cohort is really a big cohort with about 270 patients and more than 100 healthy controls. And this was really a big surprise at this time. And this publication was 1 week the most clicked publication in PubMed. So we used all the learnings from the kidney transplant and 81R. Next step, treating patients, removing the autoantibodies, and hopefully see that the patients were improving conditions. So here a paper from 2018, also pre-pandemic. 10 patients received immune absorption, and the leading molecule is always the beta 2 adrenergic receptor. So also only patients with a high titer of this marker were included in this study. So immune absorption is a technique where extracorporeal, the blood and the plasma was purified in a column. In the column, all the antibodies were removed from the plasma, and then the plasma and the blood with the cells are then going back into the patient. So the advantage is that not all very important substances in the blood were removed, but only antibodies. And here are the results. So there are 5 cycles of immune adsorption, and so I think that is as expected, that we saw a rapid decrease of the autoantibodies in 9 of 10 patients. Also, in a long term, after 6 months, beta 1 and beta 2 were significantly lower. And this is, I think, the most important, that we have a rapid symptom improvement in 7 of the patients, or the 7 responders, and also for a longer term, a sustained system improvement in 3 of these 7 patients. So this is evidence that some forms of ME are antibody mediated, and we think the answer is yes. So here are maybe some results more in detail. That is the time course here up to 12 months. This is the responder here. Patient 7 and patient 10 is non-responder. Here this area, the bottom area, is sozusagen bad conditions, and this is symptom improvement here on the top of the charts. And so here patient 5, for instance, had a long improvement in different parameters: fatigue score, muscle pain, cognitive impairment, immune score, over about 12 months. Yeah, antibody level after such a therapy is then increasing again, because the antibodies were removed, but not the cells producing the antibodies. So unfortunately, after a longer time frame, there are the antibodies coming back, and also the symptoms are coming back. So some patients are repeating such a treatment every year, for example. Now we are in the post-COVID, or in the COVID pandemic situation, so behind the real pandemic, but now an endemic situation. And I mentioned before that a viral infection is very often a trigger for ME. So we have now a lot of persons, everyone was infected or is infected with COVID, SARS-CoV-2. And so we have a lot of patients also with ME, or the so-called post-COVID syndrome. And post-COVID syndrome, also long COVID, post-COVID, is a complex of different symptoms, but ME is one of the most important symptoms. And we repeated a study at this time from patients with such long COVID conditions compared to healthy controls after COVID infection, so also fully recovered, and also healthy controls with no known COVID history. So at this time, that was possible to find such persons. I think nowadays it's very hard. And also the patients were discriminated with long COVID in patients with and without ME. At this time, our panel of autoantibody markers was much more bigger. So I want not to go into the details. You see here the different groups. So HC are the healthy controls, post-COVID healthy controls, so fully recovered. Then the post-COVID syndrome patients with non-ME and post-COVID syndrome patients with ME. And we see some markers are able to discriminate here by the asterisks, showing significance between the groups. And also a lot of markers, on the other hand, are very similar, and there are no significance difference. So again, the same situation as explained before for the transplant situation, that not all markers are able or are different. So it's really a specific effect on specific autoantibodies against specific receptor molecules. And so a short summary, we saw clear differences between the groups. And here about 77% of the patients showed different GPCR levels before. In the pre-COVID situations was only 30%, but now the panel of tested biomarkers was bigger. And also a correlation with symptoms is possible. So if a specific antibody is on a high level, we can say, okay, you have these symptoms. And also we have the same therapeutic implications. That means that you can do immune absorption. Here I would like to show you a different marker. This is the PAR1. It's the abbreviation for protease activated receptor, also associated with severe COVID-19. And PAR1 is a marker on platelets, so involved in blood clotting. And we know that a lot of patients during COVID infections had problems with blood clotting. And so we measured the PAR1 level and in different groups. So HC, with the healthy controls. Here are patients, they are hospitalized. And this here, the last one, ICU, is intensive care unit. And you see that the levels are going up, and this is highly significant. Also, with this PAR1 marker, you can discriminate between patients with thrombotic events here on the right hand and with no thrombotic events. This is a low level with no thrombotic events, or a high level if you have thrombotic events. And also this marker can discriminate and predict the overall survival. Also a high level of this autoantibody is then a bad outcome at the end. Yeah, and again, treatment by immune absorption in the post-COVID situation. That is a paper from the last year, 2025, but same setting as described before in the pre-pandemic situation, but more patients here now. 20 patients were treated with immune absorption at the Charité Berlin in the group of Carmen Scheibenbogen. And the health-related quality was assessed using a questionnaire called the short form survey SF36. There's a score from 0 to 100. 100 is then perfect. And you see here in this description here of the summary that there was an improvement with a responder have an improvement of more than 10 points in this scale. And also I will show you also that this article was also here acknowledged by the ME Association in the UK, because this is a very important article. And this is also another very interesting finding here from two independent groups, that also the transfer of the autoantibodies from ME patients into an animal model is also showing that the animals, you can transfer the symptoms into the animals by transferring autoantibody preparations from the patients. So it's the same like shown at the beginning of my talk for the transplant in AT1R. So it's like fulfilling Koch's postulate that if you transfer an agent from a affected patient into another healthy organism like an animal, and you can cause the same symptoms, then the transferred agent, so like here the antibody, is then really the root cause for the problems or for the disease. Another condition is called POTS, Postural Tachycardia syndrome. They have problems with blood pressure and orthostatic intolerance. So if you laying down, standing up, and like this one, and there was a paper from a group also using our assays to identify autoantibodies, and all the patients included in this study had at minimum alpha-adrenergic 1 receptor autoantibodies. And he was also treated, but with the IVIG therapy treatment, so not immune adsorption. And was here six patients. And so the treatment was over 6 months with one treatment every month. And also you can clearly see that symptoms are going down. The orthostatic heart rate change is going down, and a lot of problems are going down. This was normalized here in the sweet test duration time. Also, nearly all patients improved by this therapy. So we at CellTrend are working also on new markers. More markers are on their way for cardiovascular diseases, for cancer, for Alzheimer. So it's a very important tool, the autoantibodies against GPCR. It's not only for transplantation, it's not only for ME. I think we will find in the next time a lot of new biomarkers for other conditions. Yeah, I'm very grateful to our collaboration partners. That is very important for us to receive well-characterized patient samples and cohorts. I would like to start with Carmen Scheibenbogen, but she is one of our most important partners, and I hope she will also give a talk here in the future in this academy, Charité Berlin. Professor Yehuda Schönfeld, he is a world-leading immunologist. Gabriela Riemekasten, Universität Lübeck in the north of Germany, and Professor Bornstein in Dresden. And also I would like to mention here Klaus Wirth. We have a very nice collaboration. A very short overview about CellTrend. So we founded this company in 1998. We are certified. We have a quality management system special for medical devices and in vitro diagnostics. We are a very small company, about 10 employees. We are totally private, for private owners, no venture capital, so fully independent. We are located in Luckenwalde near Berlin, and we are the only manufacturer of these assays worldwide. And this is example. So we are offering also testing, but that is not our main task. So we are producing test kits, and we ship the test kits to clinical labs, medical labs for testing. But I know that it's very hard for a lot of patients worldwide to find a lab doing these assays. So we are willing, also in cooperation with the academy, to do testing. Julian will explain a little bit more now in the following slides. Yeah, thank you for listening. And I would like to hand over to Jillian for some clinical details and also explaining our collaboration. Thank you.
Thank you so much, Professor. That was absolutely fascinating and lovely to hear so much more about the background to this very important testing. I know lots of questions have come in, so I'll try to be as quick as possible, but I did want to make some further sort of clinical correlations. If you could stop sharing, Professor. Yeah. Thank you. And I'll share now, hoping that I'm on the right page. Yes, and now I'll enlarge it. So the suggested ME panel that the professor just showed us was this one, though I know it was very small on that slide, containing some of the, well, actually all of the receptors that he's already discussed. And I'll say just a few words about them, but we're going to hear a lot more because we're very, very lucky to have a couple of fantastic speakers who will be following up on this in 2 months or so. And also Professor Kai has offered to talk about further markers in about the same time frame, in around 2 months. So we're going to have a lot more on this. So I'll try and, yes. So the beta-1 adrenergic antibodies, why are they significant in ME? Very briefly, and entire articles of you, as you have seen, and indeed a fantastic book has been written about this. So this is very, very brief. They are the key receptors in cardiac cells, augmenting heart rate and contractility, and antibodies to them are therefore prone to reduce the pumping capacity of the heart. Imagine how important that is. And they also support, the receptors themselves support sodium retention in the kidneys, and antibodies to these receptors can therefore contribute to the loss of sodium. And this is called hyponatremia. It means the plasma decreases because plasma needs salt as a solute. And if you're losing salt, and why that happens is something that will be explained in the course of further seminars or webinars, but when that happens, then it can lead to lower blood volume, called hypovolemia. And indeed, it has been found in scientific peer-reviewed studies that ME patients do sometimes, maybe even often, have less blood than they should have, perhaps even one liter less, and that will hugely impact their organ function and sensations and everything. So beta-2 adrenergic antibodies normally facilitate vasodilation in the blood vessels, and Professors Scheibenbogen and Professor Wirth, who's just been mentioned, have identified that this receptor is often prevented from acting normally in ME. One reason is that the autoantibodies to the beta-2 adrenergic receptors can activate vasoconstriction within the blood vessels of the muscles instead of vasodilation. And the result of this will be to create inadequate muscular blood perfusion. And this can also contribute to the hypovolemia that we've just heard about. In other words, not enough blood. That means not enough oxygen to the tissues. And so that can cause the brain fog and the PEM and so on that patients with ME are feeling. It's also one of the main activators of the sodium-potassium pump. So this can lead to the dysregulated sodium balance that we've just spoken about. As I say, we'll hear a lot more about that and why it happens in a couple of months' time. The muscarinic M3 receptor antibodies that were shown on several of the professor's charts are responsible for example, blood perfusion using nitric oxide throughout the body, not just in the muscles and brain. And they're very, very important in the production of hormones as well, and modulate potassium channels, potassium being vitally important within our cells. And autoantibodies against them can compromise all of these functions. So you can get decreased blood perfusion, disrupted hormone function, and impaired sympathetic and parasympathetic balance. The 4 receptor antibodies of the muscarinic type are vital for learning process and so on. I'll spend less time on this because it's all getting rather complicated, but if you look at that last paragraph there, and you will have these to read because they will be up on the site, the 3 and 4 muscarinic receptor antibodies inhibit normal acetylcholine function. And that is the parasympathetic nervous system's key neurotransmitter. So of course that can disrupt normal involuntary functions and muscle movement and a lot more. And lastly, the alpha-1 adrenergic receptor antibodies, which you can also add on to the ME panel if you wish, regulate blood pressure. So they're very important for vasoconstriction of the small and large veins, and they return blood to the heart, particularly when you stand up. So if you have autoantibodies impairing this process, then you'll have insufficient venous return to the heart. And that can further contribute to the hypoperfusion that we've just seen. It can lead to reduced cardiac output, reduced tissue perfusion, and also contribute to POTS, very logically, and exercise intolerance. So I just want to mention that on AONM's website, which is aonm.org, we do have a CellTrend tab with further information. They will be adding a lot more. And this is the order form. But I just want to mention that you can order any of these individually, and you can even make your own mix. So do just ask if you'd like to mix and match, as it were. The test kits are available from AONM. It's just one serum tube, though please centrifuge it, because then the serum, when it travels, lasts longer in the tube, which we also supply, the centrifuge tube. So we make the transport to the German laboratory very easy. Our helpline does all of the organization with the couriers. And an absolutely stunning book has been written by Patrick Usher, who we're lucky to have with us here tonight as well. He is an ME CFS advocate, and he has long been studying all of the importance of what we've talked about tonight, and has actually written a book on it called Understanding ME CFS and Strategies for Healing. So I really encourage you to either get the paperback of that or the Kindle version. It's absolutely stunning the way he's made this so comprehensible. And I know it sounded complicated, but it isn't. And the actual link to these conditions that the professor has been talking about is really crystal clear. In, for example, his YouTube channel, he has many different talks. So I've got the link to it here. And he's also got a website and articles on not just this, but for example, he talks about polydipsia and has written a book about that as well. And that is something he suffered from. He won't mind me saying it because he's very overt about that. And you will notice, the therapists here, that sometimes your patients do suffer from excessive thirst. And that's, he will explain to us when he talks to us in 2 months' time, he will explain to us why that might be. Now, Professor Wirth, who will also be speaking to us, has, together with Professor Carmen, written a unifying hypothesis of ME/CFS and is developing, hopefully, a very important remedy for this called Metodicure. And this is now being co-funded by the European Union, I believe, to quite a high amount. So it's fantastic that that funding has come through. And he, to a certain extent, I believe, sees this as an acquired mitochondrial myopathy. So that's fascinating. And we'll hear a lot more about that. Just to say that there are many interviews with him and with Patrick Usher that have been, conducted by specialists and doctors in the UK. For example, Dr. Vinita Kane, who's here with us today from the Long COVID Clinic. She's conducted 2 interviews with him on the underlying causes of ME, a unifying hypothesis. So please do tune into that. And there's one with Dr. Sanjay Gupta, who we know well, a brilliant cardiologist from the UK who's done interviews, an interview with Professor Wirth and Patrick Usher. And this one on blood volume and excessive thirst with Dr. Eric Gordon from Gordon Medical is well worth listening to. That is linked here, and so on. So lots and lots on this topic is actually available. And so I'd just like to encourage you to look into those resources before our next webinar. And thank you so much. I'll now switch off my presentation and we'll turn to just a few of the questions. I did mention that we might continue a little bit longer than 8 o'clock today. So for those who have to leave, this will be recorded and up on our website very soon. So thank you, Professor. I'll look at some of the Q&A questions to start with. Does immunoabsorption take out all the antibodies, even the good ones that you need to be immunocompetent?
Yes, unfortunately, this is right because it's non-specific for specific antibodies. It's on the column is a substance like protein A or protein G that binds all of our antibodies. Sometimes then you will receive after the treatment injection with normal immunoglobulins. But I know that some therapists are not longer doing this. But
okay,
it's really right. I would like to point out that it's not a specific absorption therapy for maybe beta 1 or beta 2 or M3 and M4. But this may be also an advantage because maybe there are other GPCR autoantibodies. So I explained that we have 770 different GPCRs in our body, and we have now tests available for about 35, 40 different antibodies. So it's a very small first insight into this area. And maybe by the removal of more antibodies, you also remove other GPCR autoantibodies, may be present, but not discovered yet.
But they do come back, as you explained, and the same with rituximab. It doesn't get rid of them forever. They will come back.
Yeah, but
right?
rituximab will last. There is hope that they will last forever, for longer. If you destroy the cells producing the antibodies, they are generated at a certain time point. So there are some studies, and also Carmen Scheibenbogen is planning new studies with the next generation of anti-CD20, anti-CD19 drugs. So
okay, yeah, it's very, very important to have these markers, which we've never had before so much with ME, depending on how one defines it, and we'll get onto that.
We are now at the end of the beginning of the research of GPCR autoantibodies at diagnostic markers. So we have a first beam into a black room, yes?
Yes. Well, a question here that was asked previously as well is, do you think that these antibodies can cause small fiber neuropathy?
Yes, we have some other antibodies, FGFR3, for example, and TSHDS, that we know have a correlation with small fiber neuropathy. But the correlation is normally not with the antibodies I talked before here this evening.
Not the B1, B2,
Not
M3,
B2, not
M4.
M3, yes.
Okay, so there's another panel for that, and that is labeled actually a small fiber neuropathy.
Yes.
Yes, Keisha, the slides do explain what immunoabsorption is, so please don't worry. You will be able to see that in the presentation. She asks, is this treatment available in the US, or is it only available in Germany?
I guess it's available in the US, yes. Normally, the patients have to pay for their own for this treatment, yes. Also in Germany, it's not part of the normal health insurance system. I don't know the situation in US. I'm sure it will be available in US with a high-level healthcare system and clinics, yeah, on the highest ranking also in the world. Yes.
I'll just ask a couple more from here. Mr. Smith asks, is there a blood or urine test available in the UK or Europe that proves that a patient has CFS-ME? Well, I mean, you've seen, Mr. Smith, that this one does correlate closely with conditions that have been termed ME CFS, and what the, evidence for the controls and the non-controls was, we will talk about in a moment, because I saw a question coming into the chat on that. But, I think it's difficult to use the word prove, isn't it, Professor Kai? Actual evidence is a difficult word to use, but you've used the word correlation a lot, haven't you?
Yes, yes. So here's also, I see a very interesting question that was, how do you explain that only 1/3 of people have GPCRs, autoantibodies?
Yes, let's go on to that one.
The 1/3, the 30% was in the time of the pre-pandemic. That was our first study where our marker set was only having 15 or 10 different markers. In our paper here published in the COVID situation, I pointed out that we have about 77% of positive patients with autoantibodies, but we have then at this time a broader panel of autoantibodies. So you see, maybe next time in 2, 3, 5, 6, 10 years, if we have more antibodies available for testing, maybe the number of patients will going up. But also, Vasia, do you think that they have a different pathological mechanism? So yes, we are not sure that all the ME patients have an autoantibody background. We don't know.
There's so many causes of it, can't
Yeah,
there?
we don't know at this time.
And it depends a bit on the definition of it, doesn't it? Whether the international consensus criteria have been used or the Canadian criteria and so on. There's a very important question here, I think, as well. I mean, they're all important, but this one I was referring back to earlier. Thank you for your brilliant work. How have you derived the normal range for the CellTrend autoantibody test?
Yes.
How many health controls have been used to derive the normal range? And is the presence of autoantibodies always associated with disease?
Okay. Yeah, I showed in some of the slides really raw data, yes, where we have a correlation of the data see maybe 100 and more healthy controls. So for the first study in ME in 2016, it was healthy controls 108 individuals, yes? And so we are working all the time. We compare two different groups and see if they are totally have same levels or if there is a differentiation between high levels for patients and a lower level of healthy controls. We know that also, yes, some healthy persons have in this group of healthy controls. So there is an overlap. it's not a black-white picture. So that is very rare in medical research. There is an overlap. We have a sensitivity of a test. We have a specificity of a test. If you have autoantibodies alone and no symptoms, then it's not ME. That is possible. So if you have both, you have the symptoms, you do the test, and you have a high level, then we can correlate this. But if you are doing the test, have no symptoms, then you cannot say I have ME, for example.
And studies are ongoing, of course. There will, by the way, be a conference to which we're all invited. It's going to be free live streaming in May by the German, very, very active ME Foundation. And that is, I think, on the 7th and 8th of May, but we'll be sending out information about that and how you can get your free tickets. It's in Berlin. And it is driven very, very importantly by Professor Scheibenbogen. And you will be there, of course.
Yeah, and also Yehuda Schönfeld.
He comes over.
I think every year there. So very well-known researchers are there and giving talks every year now. Update on ME.
And then, do you think episodes of post-exertional malaise will cause the body to increase its production of autoantibodies?
So not tested yet. So that have a course of samples over time from a patient, yes. But my personal impression is that this is not the case because antibody generation takes some time, yes. So so antibody is not a very fast regulated trigger in our body, yes.
Are there any known preventative measures one can take to avoid increasing autoantibody levels with ME?
Not known. That I think that is an autonomous process, yes, that the body is producing such autoantibodies. There is no research, maybe having a clinical study, a prospective clinical study, yes, with some different options in one group, and then see if there is a lower level of autoantibodies at the end. There is no knowledge on this, and I think it's also very hard to find a substance, whatever a treatment, to avoid the generation of autoantibodies.
Yes, and then there are points here that are, of course, very, very important. If clients are tested and they do have these antibodies, what are the treatment options potentially available to them? Well, some have been mentioned, but there are others, of course, and we'll have Professors Wirth and
Carmen,
Patrick Usher, also
Carmen
Professor Carmen Scheibenbogen talking about other options. There definitely are many, depending on the different sort of levels at which you look at it. It doesn't just have to be filtering out the antibodies from the blood or giving rituximab or whatever. But I don't want to sort of, jump the gun and start talking about those now. And I don't want to sort of force Professor Kai to, because he always emphasizes very, I think, Professor Kai, you say that you're not so happy talking about the clinical options unless they're ones that have gone through your scientific studies. Is that correct?
Yeah, so we are focused on the autoantibodies and treatments option on autoantibodies only. There are a lot of other options, maybe so all with the background to bring muscle function back to normal function, so the energy level, yes, all the
yes.
There are a lot of substances,
like the mitochondrial myopathy that Professor Wirth talks about.
Giving energy to the muscles again back.
And the microclots that can be involved, and which I know is discussed in your conferences, and the low blood volume. There are many ways of dealing with this sort of systemically and not just looking at the one action that's going on. But we'll be covering this in the course of the next 3 months.
yes, a treatment focused on the antibody level and autoantibody removal is a harsh treatment. Yes, so from my personal opinion is that is for patients they are very hard affected. Yes, laying in the bed all the time, not able to do their normal life. Yes, so we have some cases laying down in a dark room.
Of course,
So
many 25% of the patients.
So like this
in the
one,
UK.
yeah. And in such conditions, you can think about such a treatment also with high costs. And we see a lot of recovery and great improvement in such patients. That is sort of the focus, yes, of if we do such a treatment.
Yeah, we'll be covering a lot more of that. And I do just want to mention again, Patrick, who's here this evening, Patrick Usher, he also has a Patreon channel and does talk to patients once a month. And he is one himself, he admits that, and is much better than he was, but we'll be hearing a lot more from him too. So lots and lots of, I think, optimism ahead. For the kit sample, Celine says, we cannot have it in France, very complicated. Celine, we can send that to you. So please do contact AONM. Please could you, Hayley, pop the AONM helpline into the chat, which is info@aonm.org. So just contact them and they'll get it sent to you. Does IVIG also contain autoantibodies?
Good question. I think it's a drug preparation. Yes, IVIG. It's commercial, like a commercial drug.
It's very well filtered, isn't it?
But it's antibodies. It's immunoglobulin preparation.
Yeah,
so
right.
if it's, I think it's always a mixture from a pool of different persons. Yeah, where you then purify it from the blood, from this serum or from the plasma. I don't know the preparation steps. Theoretically, I think this is positive. It's possible if you have some positive donors in this pool. I think it's not tested nowadays for the presence of such autoantibodies. I think I remember there was one, or we plan to do this, that we buy some of the preparations and test for autoantibodies. Yeah, but this is a project for the future.
Hopefully the negative ones have been filtered out. I know that IVIG is used frequently in some hospitals, at least, for the PANS-PANDAS patients. And we do have a lot of activity with PANS-PANDAS at AONM because we do a very, significant panel for that in the States called Moleculera. And IVIG is frequently used. So I'm imagining that the very good, well-filtered types do not contain pathogenic antibodies, autoantibodies. But let's discuss that also together with Professor Shimazaki, who we'll have on very soon. Anthony is repeating Lucy Clark's question about if patients do have antibodies, what are the treatment options? Anthony, I'm hoping that together as a group, not just top down, but in the future webinars that we have, we'll be able to cover that. As I say, that there do appear to be a lot of options beyond just those that we've talked about this evening. Though, of course, we do know of patients who've gone to Germany and had inusphoresis and so on, which is also available here in the UK, but it tends to be expensive and difficult and not available to the bedbound patients. So let's make that a kind of project, is to start gathering those treatment options or therapy options, because they do exist. I mean, I personally don't want to make any promises, but we'll be discussing them in a group. And I'm so looking forward to the next webinars that we're going to have. I don't want to go on too long. It's already 10 past, but just one more perhaps from here. An attendee says, I have small fibre neuropathy, but TSHDS and FGR3 are negative, yes. But I have GPCR autoantibodies. So can this be linked? In other words, small fibre neuropathy patients can presumably have other autoantibodies and not those specific ones, would you say?
Yes, so it's the same like for ME. We have not a 100% correlation. So we cannot find in 100% all of the SFN patients the both specific autoantibodies. Yeah. So like the 80% we have now for the ME patients, yes. I don't know the rate yet here by top of my heart for the SFN patients.
Well, maybe next time when you're talking about other markers, you can cover that.
Yes.
That's fascinating. And last question here for now. If you are taking IVIG, will it affect the testing of CellTrends, would you say?
If you have the antibodies in your blood, then we will find them.
Okay.
Hopefully, the level is reduced by the therapy at this point, yes. But it's not blocking the antibodies. This is really disturbing the assay, yeah. So that there are antibodies, autoantibodies present, and we can't find them. I think that is not the case.
Okay. Yes, thank you. Well, I don't want us to take up too much of your time. I know it's an hour later in Germany as well. So
no problem.
huge thanks. It is a complex field, isn't it? But I think we're getting through the complexity to, as you said, the sort of light at the end of the tunnel is beginning to become evident in autoantibody generated, or at least
yes,
where autoantibodies are correlated with ME. And let's continue talking about this as regularly as you have time and the others. And we will, as I say, be having another couple of talks about this within the next 2 to 3 months, most definitely. And we'll send you out all the links and that we had in today's presentation. The recording will come in an email to you, and it'll also be up on the website. So thank you, everyone who's been here. Huge thanks to you, Professor Kai, as well, and to all of your team.
Yes, I highly appreciate your work at AONM, organizing such webinars, and it's overwhelming for me to see the interest, the audience, or how much people are interested here in watching and hearing our webinar.
Yeah.
Thank you.
Doing fantastic work. Thank
you to all of them. Yes, and all best, and may your conditions be improving very soon.
Thank you. We do have another webinar coming up, and it'll be about Lyme/PP. That's PANS Pandas. I can't remember the date, to be honest, but it's on the events on aonm.org, and that's going to be a fascinating webinar with Dr. Eileen Oostemier from the States, who we've had on before, and Professor Leona Gilbert and others. So thank you very, very much.
Okay.
Bye-bye.
Good night then.
Good night.
Bye-bye.